Hello everyone, I am Dr. Akshatha from the Department of Oral and Maxillofacial Surgery, Yenepoya Dental College. I will be talking about unlocking the jaw, understanding and managing TMJ disorders. So, if you look into the anatomy of temporomandibular joint, we have a condylar component, a fossa component. There is an articular disc in between both the components and a retrodiscal tissue on the posterior aspect and the muscle attachment on the anterior aspect. There is superior and inferior joint spaces between the articular disc and the bony component. If you look at the synovium, synovial membrane is a lining of the capsular ligament. Synovial fluid contains high concentration of hyaluronic acid, and there are other contents like albumin and very little percentage of globulin, alkaline phosphatase and leukocytes. Age changes in the joint, it will lead to decrease in the synovial fluid formation. There will be impairment of motion due to a decrease in the disc and capsule extensibility, decrease the resilience during mastication due to chondroid changes into collagenous elements, dysfunction in older people. TMD. So, what is temporomandibular disorders? It is a collective term used to embrace a number of clinical problems that involve the masticatory musculature and the temporomandibular joint itself. If we look at the classification, there is a muscle disorder, condyle disc component disorder, structural incapabilities and others. What I will be discussing more of is a condyle disc component today. So, what happens in the temporomandibular joint? So, when there is a joint overload, the cartilage metabolism is imbalanced. There is degradation of the tissues which exceeds the buildup and leading to biomechanical failure. So, this will lead to change in the position of the articular disc. Now, there are multiple things that can happen with the change in disc position. One is a painless click which happens in 30 to 40% of the patients. Then there is if the cartilage degradation continues, it leads to osteoarthritis or disc perforation. Now, osteoarthritis presents as localized pain, whereas disc perforation will present as crepitus. There are other things that happen like synovitis, adhesions and fibrous ankylosis. Disc displacement with reduction. So, the displaced disc, if it recaptures its normal relationship with the mandibular condyle during the mouth opening, it is disc displacement with reduction. Now, this will present itself with a click on opening and closing. Then there is deviation of the mandibular midline to the affected side early on opening and it goes back to its normal position on closing. There is pain resulting from the strained discal ligament or condylar pressure and there is restricted mouth opening. Now, what is disc displacement without reduction? Here the displaced disc fails to reduce or recapture to its normal position when the condyle opens, unlike the disc displacement with reduction. So, sudden or absence of joint click associated with restricted mouth opening. The clicking that was present while previously becomes absent. Mandibular midline deflection. There is limitation of protrusive excursion with deflection to the ipsilateral side, severe articular pain and restriction of the lateral movement to the contralateral side. What are the keys in making a differential diagnosis? Firstly, the history, then clinical examination. We have to check for the end feel. Now, there is a hard end feel and soft end feel. Hard end feel is when patient opens the mouth to around 25 to 30 mm dislocation, which gives a hard end feel, whereas the muscle disorder gives you a soft end feel and it occurs during any time during opening. In clinical examination, we check for the tenderness, the trigger points, the muscle mass and muscle tone. In the joint, we check for swelling, tenderness, hinge translation, the jaw deviation, range of movements, clicking or crepitation and timing of the click. We check for acute malocclusion, we check for restriction in mouth opening, loading of the joint and diagnostic anesthetic block. Now, acute malocclusion is when either the patient has a disocclusion of the ipsilateral posterior teeth and heavy contact on the contralateral canines, or the patient tells that the teeth suddenly don't fit right, and this displacement, patient has loss of ipsilateral posterior tooth contact. These are the key points in diagnosing what kind of a disorder the patient has. Now this test called as a loading the joint, it is also called as Mahan's test. So what is done is a tongue blade is taken and a patient is asked to bite on the canine between the upper and lower canine. So if we check on the left canine, the right canine gets loaded, the right TMJ gets loaded, and if the patient has pain in the right TMJ, then Mahan's test is positive, and vice versa. Diagnostic anesthetic block. Here for the diagnostic purpose, to differentiate between the muscular pain and the joint pain, we give an anesthetic block. So mainly auriculotemporal nerve block it can help us rule out the intracapsular disorder. Now clinical diagnosis, we have disc incoordination, disc displacement with reduction, disc displacement without reduction, and anchored disc. Now in disc incoordination, it is the earliest indication of friction, there is no pain, there is a sudden terminal jolting when closing, and gives some unstable condyle disc relationship. Whereas this displacement with reduction, the disc moves in the anterior medial direction, the condyle catches up with a click, and reciprocal or opening and closing click is there. Now the degree of displacement could be early, middle, or based on the late stage, degree of displacement can vary. Now it has a unilateral deviation, the mandible has a unilateral deviation to the affected side, and in 30 to 40% of the cases they are asymptomatic. Disc displacement without reduction, mouth opening gets reduced, and there is pain or overloading, or because of the overloading or stretching of the retrodiscal tissues, deviation on opening to affected side, prior history of click or pop, and muscle soreness because of some extra effort that is taken by the joint. Anchored disc is when sudden or severe persistent limited mouth opening is seen. There is restriction of severe, that is up to 10 mm also. No pain as disc is not displaced. Now if you see in these images, you can see there is a first column that gives you a closed mouth position and second column with open mouth position in normal anterior disc displacement with reduction and anterior disc displacement without reduction. If you see the first row of images, it shows a normal disc position on closed mouth and open mouth position. In the second row, you can see anterior disc displacement with reduction. So on closing the mouth, the disc is left behind, whereas on opening, the condyle catches up with the disc. Whereas in disc displacement without reduction, as you can see on closing and while opening, the disc does not come back to its original position. If you see the imaging for internal derangements of the temporomandibular joint, we have mainly the orthopantomogram, MRI, and CT or CBCT. Now MRI is a gold standard as we get both soft and hard tissue diagnostics. We can see the disc position and morphology, the retrodiscal tissue status, bone marrow changes, degenerative changes, and joint effusion. Whereas orthopantomogram is a 2D imaging and gives us a very vague idea of the bony structures in the joint, and CT or CBCT in the same way, it gives excellent cortical bone abnormalities. It gives us imaging diagnosis about sclerosis and surface erosions. Here, if you see the images, this is a MRI scan, the T1 and T2 images in closed and open mouth positions. So the first row gives us a normal joint scan wherein the disc position is normal. Here in the second row, you can see the anterior disc displacement with reduction. If you see here the disc is gone back to its normal position, whereas here the disc is anteriorly displaced. Similarly, in the third row, if you see, there is a displaced disc as well as it is still displaced when closing the mouth. So, this is the MRI of temporomandibular joint. After MRI, what we have in the latest diagnostic aid is an arthroscopic procedure. So, with the arthroscopy, we can see what is happening live with inside of the joint, like retrodiscitis, adhesions, you can see synovitis, large perforations in the disc. All these can be visualized in an arthroscopy. So, when a patient presents to us, patient may present with a muscle disorder, an intracapsular disorder, a primary intracapsular disorder with a secondary muscle disorder, a primary muscle disorder with a secondary intracapsular disorder. Now, this is very difficult to manage as such because of its multifactorial origin. Key things in its management is to reduce or eliminate the pain, improve function, improve diet, decrease the pain medication dependency and correct any deleterious habits if present. Conservative management involves reassurance to the patient, patient education, medications for pain and habit management if there are any deleterious habits, rest, psychological evaluation of the patient, removable occlusal appliances that I will be talking about, physiotherapy and jaw exercises, occlusal adjustment and trigger point injections. Now, appliances. What appliances can we give to a patient? So, it can be either hard or soft orthotic splint or a partial coverage or full coverage splints. Now, what does these appliances do? They prevent the condyle from resting on retrodiscal tissues by decreasing the inflammation and allowing the disc to reduce to its proper position. It protects the dentition during clenching and grinding. Now, there are different types of appliances. One is the muscle relaxation appliances or stabilization appliance, which reduces the muscle activity. This can be given when it is a joint pathology in combination with the muscle secondary muscle disorder. So, it gives a joint stabilization, protects the teeth, redistributes the occlusal forces and relaxes the elevator muscles. So, wearing the appliance increases the patient's awareness of the jaw habits and helps alter the rest position of the mandible to a more relaxed open position. Now, according to this article, centric relation evidence base. So, the authors tell that if the teeth are in maximum intercuspation, no matter what the joint position, they will bear the maximum forces of the elevator muscles and not the joints. Now, what are the uses and limitations of these appliances? It can decrease loading of the joint, it can reduce the muscle activity and muscle hyperactivity, it can reduce the internal derangement symptoms and it can protect the teeth. What these appliances cannot do is retrain the muscles, recapture the disc, eliminate parafunction, establish proper vertical dimension and reprogram the muscles. So, with this conservative approach, we can manage 90% of the temporomandibular disorders, whereas a very small percentage of 10% requires surgical management. Coming to the surgical management, we have arthrocentesis and arthroscopy being minimally invasive procedures, disc repositioning procedures, discectomy and arthroplasty and joint replacement procedures with alloplastic and autogenous replacements, joint replacement being done at the end stage of the disease. So, to conclude, I would like to say that temporomandibular disorders are a set of complex multifactorial in origin disorders. So, here the diagnosis is the key to solving the problem. Thank you.